Hello and welcome to our new topic. Today we will be discussing Autacoid pharmacology, focusing selectively on prostaglandins, histamine, and serotonin. These are locally acting mediators that play a central role in inflammation, allergy, pain, and vascular regulation. Understanding these mediators allows us to directly connect basic physiology with clinical pharmacology, especially in common conditions like asthma, urticaria, and fever. The viewers are encouraged to watch other related lectures in this playlist on this channel for a broader base. So, let's start. The learning objectives are shown. Please take a look. In this session, we aim to define and classify autacoids and understand how drugs can either mimic or block their actions. The goal is not just to memorize pathways, but to relate these mediators to clinical conditions and rational drug use. Autacoids are locally acting chemical mediators derived from various sources. They function in a paracrine or autocrine manner and have a short half-life. Their main role is to regulate local tissue responses such as inflammation, blood flow, and healing. The key point here is that they act locally but have powerful systemic implications. Autacoids can be classified into lipid-derived mediators such as eicosanoids, amines like histamine and serotonin, peptides like angiotensin, and gaseous mediators like nitric oxide. This classification helps us understand their origin and mechanism of action. This lecture focuses on eicosanoids, histamine and serotonin. Autacoids primarily take part in inflammation and repair. In this diagram, histamine, serotonin, and prostaglandins are shown to participate in inflammation in sequence. Early phase responses are dominated by histamine, while later phases involve prostaglandins and leukotrienes. This explains why different drugs are needed at different stages of inflammation. Now, let's talk about them one by one. Eicosanoids are lipid-derived autacoids originating from arachidonic acid. They include prostaglandins, thromboxanes, and leukotrienes, all of which have diverse physiological and pathological roles, as we shall see next. Our cells are covered by a lipid membrane made up of phospholipids and cholesterol. Arachidonic acid is a long-chain fatty acid that is part of the phospholipids. In case of tissue injury, it is released from the tissue membranes and metabolized through COX, LOX, and cytochrome P450 pathways. This is where pharmacology becomes very relevant, because drugs like NSAIDs inhibit at the COX level, while leukotriene antagonists act on the LOX pathway. We will talk about the inhibitors in separate lectures. Prostaglandins act on a variety of G protein-coupled receptor subtypes, which possess signaling mechanisms. While detailed, the key takeaway of this table is that different prostaglandins act through different receptors, producing diverse effects depending on the tissue. Now let's see the relevance of eicosanoids. Let's start from the cardiovascular effects of prostaglandins. Prostaglandins such as PGI2, also known as prostacyclin, are potent vasodilators and play a protective role by inhibiting platelet aggregation. In contrast, thromboxane A2 promotes vasoconstriction and platelet aggregation. The balance between these two determines vascular tone and thrombosis risk. Clinically, this explains why drugs affecting prostaglandin synthesis, such as NSAIDs, can influence blood pressure and cardiovascular risk. The role of prostaglandins and related compounds in platelet aggregation, inflammation, immune response, fever, and pain perception is shown in this slide in detail. Take your time to explore it. Similarly, prostaglandins have important effects on the respiratory system. Certain prostaglandins, particularly PGF2-alpha, can cause bronchoconstriction, whereas others may cause bronchodilation. However, in clinical practice, leukotrienes play a more dominant role in bronchospasm. This distinction is important because it explains why NSAIDs are not very effective in asthma, and in some cases may even worsen it due to shunting toward leukotriene production. Eicosanoids have effects on the gastrointestinal tract also. Prostaglandins promote mucus and bicarbonate secretion while reducing gastric acid secretion, thereby maintaining mucosal integrity. When we inhibit prostaglandin synthesis with drugs such as NSAIDs and corticosteroids, this protective mechanism is lost, leading to gastritis and peptic ulcer disease. This is one of the most clinically important adverse effects of NSAIDs. Prostaglandins also help regulate aqueous humor flow in the eye and thereby reducing intraocular pressure. Hence it is useful in the treatment of glaucoma. This is a good example of how a physiological mediator can be harnessed therapeutically in a targeted manner. In the kidney, prostaglandins help maintain renal blood flow, especially under conditions of stress such as dehydration or reduced perfusion. They act as local vasodilators, preserving glomerular filtration. When NSAIDs inhibit prostaglandin synthesis, this compensatory mechanism is lost, which can lead to acute kidney injury, particularly in vulnerable patients such as the elderly or those with pre-existing renal disease. Prostaglandins have very important effects on the reproductive system. In females, they are involved in uterine contractions and are used clinically to induce labor or medical abortion. Conversely, inhibition of prostaglandins can delay labor, such as happens when strong NSAIDs are given as tocolytics. Understanding this dual role helps explain both therapeutic applications and potential risks during pregnancy. Likewise, prostaglandins have important effects on male reproductive system. They are helpful in treating erectile dysfunction when administered or injected directly. As discussed here, inhibition of eicosanoid synthesis is more useful clinically than their stimulation. Glucocorticoids act upstream by inhibiting phospholipase A2, NSAIDs act on COX, and leukotriene inhibitors act on the LOX pathway. This explains drug selection in conditions like asthma and inflammation. You may watch separate lectures on these topics on this channel. Now let's talk about histamine and serotonin, two important biogenic amines. Histamine does not have any therapeutic uses in modern practice, but antihistamines surely do. This section introduces antihistamines, which block histamine receptors. These drugs are particularly useful in allergic conditions and represent one of the most commonly used drug classes in clinical practice. Histamine is a biogenic amine synthesized from histidine and stored mainly in mast cells and basophils. It is released during allergic reactions and plays a key role in inflammation and immediate hypersensitivity responses. This classical response demonstrates histamine's effect on the skin, producing redness, flare, and wheal. It is a useful clinical model for understanding urticaria and allergic reactions. Mast cells, IgE, and cytokines play an important role in allergic reactions. This diagram shows how early and late phases of allergy develop, linking cellular immunology with clinical symptoms. Thus, histamine release has immunological etiology. This diagram shows that apart from immunologic mechanisms for histamine release, such as IgE-mediated activation, several non-immunologic triggers also exist, such as some drugs or physical stimuli. This explains why some patients develop such reactions without classic allergy. Histamine binds and stimulates its receptors. There are at least 4 types: H1, H2, H3, and H4 receptors. The most clinically relevant are H1 receptors, involved in allergy and bronchospasm, and H2 receptors, involved in gastric acid secretion. Clinically, we don't use histamine but its inhibitors. Histamine effects can be blocked pharmacologically using antihistamines or prevented by stabilizing mast cells with drugs such as glucocorticoids, cromolyn and nidocromil. In severe reactions like anaphylaxis, physiological antagonism with epinephrine is essential that does not depend on histamine receptors, but rather on a physiological bypass mechanism. H1 blockers could be divided into 2 chronological groups: first and second generation antihistamines. First generation drugs are sedating and possess antimuscarinic effects, while second generation drugs are more selective, generally non-sedating and better tolerated. Choosing between them depends on clinical needs, such as sedation, antimuscarinic function or daytime use. Here, first and second generation of antihistamines are compared in terms of their receptor selectivity, sites of action and peculiar characteristics as a group. First-generation antihistamines can be divided into 5 chemically distinct groups. They differ in terms of their receptor selectivity and can also block muscarinic, dopamine and alpha-adrenergic receptors, in addition to the intended histamine 1 receptors. Their antimuscarinic property may determine their indication and contraindication as described in next slides. Second-generation antihistamines have fewer agents and less individual groups. Fexofenadine, loratadine and cetirizine are commonly used drugs in this class. Antihistamines have many important effects that determine their clinical uses, as given on this slide and also on the next. The side effects are given in italicized font. The primary utility of antihistamine drugs is in controlling allergic and histamine-dependent inflammatory conditions, such as rhinitis, hay fever, urticaria, etc. They treat motion sickness and dry up the exocrine secretions of eyes, nose and mouth by virtue of their ability to block H1 receptors. On the other hand, H2 blockers help reduce gastric acid secretion. Antimuscarinic side effects are possible, such as dry mouth, blurring of near vision, urinary retention and constipation. Alpha-adrenoceptor blocking effect may cause orthostatic hypotension, while sedation and extrapyramidal symptoms, all arising from blockade of other receptors. There are practical considerations in prescribing H1 antagonists. When prescribed to patients, it is important to give them clear information, such as precautions, including sedation, drug interactions, and contraindications such as in patients with prostatic enlargement, if using first-generation drugs. This section introduces 5-hydroxytryptamine or serotonin, another important autacoid involved in vascular tone, gastrointestinal function, and central nervous system activity. Serotonin is synthesized from tryptophan and has multiple receptor subtypes. Its effects are widespread, which explains its role in conditions like migraine, vomiting, and psychiatric disorders. This table summarizes serotonin agonists. The key clinical takeaway is the use of triptans and ergot derivatives in migraine as well as some other conditions, which are highly relevant in everyday practice. Take your time to explore this table. This table summarizes serotonin antagonists. The key clinical takeaway is the use of ondansetron in severe vomiting secondary to general anesthesia, abdominal surgery, and cancer chemotherapy, which are highly relevant in everyday practice. Take your time to explore this table. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!